the Division of Primary. Great, thank you. In the Division of Primary Care and Population Health. For those of you who haven't been to our lectures before, the general format, we have a little bit of introduction, a presentation from our esteemed colleagues, in this case, Dr. Sam Thomas and Marini Kim. And then we have quite a bit of time for a conversation and discussion. And so I would just encourage you as we go along at any point in time to put questions in the chat, and then we'll be ready to have a conversation with Sam and Marini as we go along. Selena, are there any SMCI announcements that we need to do before we get started?
No announcements. I'll be putting the CME in the chat. So if you don't already, please sign up for CME, and then you'll get your credits for today's lecture.
Fantastic. Thanks so much, everybody. We're still climbing. Maybe we'll wait just one more minute, or maybe I'll give Sam and Marini a long introduction. So I'm welcoming Sam Thomas and Marini Kim. Dr. Thomas comes to us from Intermountain. He is a Stanford Intermountain Fellow and a surprise entrepreneur. So Sam and Marini are going to talk to you about PocketRN, a project that Sam has been leading and Marini has been really taking charge of. This is based on a Catalyst grant that Sam got here and then has become a full-fledged company. Sam is now the Chief Medical Officer and co-founder for PocketRN. And just a little bit more about him, you know, his work focuses on implementation science, health services research, and population health. And I think you'll hear all of those themes come together. He's been published in the New England Journal of Medicine. I'm definitely jealous of that. And I'll say as well, while Sam has been growing this company, he has also been growing his family. And so Sam, in addition to a brand new company launched during the pandemic, Sam has 3 children, a 5-year-old, a 2-year-old, and a 1-year-old. And I'll let you guys do the math about how all of that was happening all at the same time. Marini comes to us. She's a trained nurse. And Sam, I might let you introduce Marini a little bit more before we get started. And we're just really glad to have you here talking about PocketRN. Sam's a great person to ask about, you know, what really happens in a clinical trial, about transition from internal medicine to a startup setting. He's really got a broad view of different perspectives in this implementation and improvement work. All right, Sam, I will turn it over to you.
That's great. Thank you so much, Katie. Yeah, really excited to be here. I've looked through a lot of the SMCI lectures and have always wanted to participate. So this is really exciting. Katie came to talk to us about this. We were eager to have this opportunity. And Marini is here and will actually help with some of the slides as well. I'll be giving the majority of the presentation today, but by all means, we'd hope that people would stop and ask questions along the whole process. We have a lot of content here, but we don't need to get through all of it by any means. And this is a really exciting topic for us to talk about specialized virtual nursing care. And we will go ahead and jump right in. So we'll pull up those slides and we'll get going. And so again, the title of this talk, as you probably saw in the announcement, was Enabling Nurse-Led Specialized Virtual Care at Stanford Healthcare. And we've gone through an interesting journey, and people might have questions specifically just about the journey itself. If that's the case, please feel free to stop and ask as well. But to go to the next slide, I can just do a little bit more of a brief introduction. We decided that I would be presenting most of it, and so I don't have Marini's information here, but I'm happy to give her an introduction as well. So as a brief disclaimer, I am the co-founder and chief medical officer of PocketRN, and so that is my background. As Katie mentioned, recently finished the Stanford Intermountain Fellowship in Population Health and Delivery Science, similar to Stacy Valender, who's on the call, who was my mentor and idol in many ways in the program a year ahead of me. And I get the great opportunity of working with Intermountain now as a fellow in their health, in their postdoctoral fellowship in the Healthcare Delivery Institute, and I'm practicing internist, but have lots of amazing continued connections with Stanford, including still being a Stanford student in the master's program in health policy. And I'm wrapping up my master's thesis here soon on social determinants of health, a collaborative project with Stanford Intermountain. And so that's a little bit about me and Marini, who's got a doctorate of nursing. She's a nurse practitioner who did her training at Johns Hopkins and is still teaching at the School of Nursing at Johns Hopkins, and spent a lot of her clinical experience working both in primary care and pediatrics, and then at Children's National Hospital doing rare bone disease, which is a fascinating experience for her to bring to the table, which is really understanding complex conditions for patients that have, in many scenarios, unknown diagnoses and trying to navigate this crazy world called healthcare. But next, I'll dive a little bit more into just the timeline for how this project came to be. As you heard from Katie, it started as an interesting project that then became a company and continues to kind of grow and develop in interesting ways. And I always talk to all my colleagues outside of Stanford, and everyone looks at me and says, "Oh, it's a very Stanford thing. It's for you to do research, and then it becomes a company, and it goes on from there." And from my experience, it's been a really interesting process, and I've learned an immense amount from the beginning to today, and I'm sure I'll continue to learn. But it really began with the Stanford Biodesign program, where I was on a team with 400 individuals that was put together through the Stanford Biodesign class. 4 of those individuals of the original, so there was 5 other individuals. Originally, there were 6 of us. 4 of them are still working on the idea today and working on the company. That was in March 2020 when we took our original team, saw what was happening with COVID, and then decided to pivot to address an issue that we saw was going to be critical for our healthcare ecosystem. And then we later incorporated in January and had a wonderful opportunity to partner with the Stanford Medicine Catalyst team and SHG Nursing Leadership and began working with the ESU. The reason for that incorporation in that initial fundraise was because we needed to have funds to be able to test the feasibility of this project in a health system. And we knew that takes a significant amount of money and time and effort to do that. So that was our personal journey there. We then received IRB approval and worked with Dr. Esu Evaluation, who's our PI. That was all approved in April. And we started to onboard and recruit nurses for that project, beginning in the Advanced Wound Care Clinic. You'll hear more about that in just a minute. In June, we started to enroll our first patients in the Advanced Wound Care Clinic, and then expanded to a second site in the Vascular Clinic in November. We just wrapped things up in April of this year. So that's a little bit of the timeline for PocketRN. And just to tell you a little bit about the team, again, a number of these members I met while at Stanford in that Stanford Biodesign class. But we feel really lucky to have had the opportunity to work with some amazing engineers and designers and UX UI experts and others to really put together what we feel like is a strong team of individuals that can understand and strive to change the way that people experience healthcare and how nurses can deliver that care. And so just a quick stop here, as well as I would call out some amazing collaborations with the Biodesign program, Catalyst, and the ESU. But we can move on and jump more into the meat of the background of the problem that we want to talk about. So here, I wanted to start with an interesting quote. And this quote comes from interviews that were performed by Monique Lambert, who works at Stanford in the Nursing Innovation Informatics group, who spent hundreds of hours shadowing and interviewing nurses to understand what their work is. And I think this quote really captures an important nursing perspective, namely the invisible work that goes unnoticed by nurses. And I'll just read it out loud. I'm sure you already maybe read it at this point, but this one nurse stated that we're in a place of quality, of safety. And our modalities are becoming more complicated. We have a fall prevention plan that is 20 steps deep. We have a skin prevention plan and bundles that are multiple layers, and sometimes it takes just one thing to throw it off. For example, we need to track down equipment and use it, and then clean it every time. Nobody considers that doing that takes an extra 20 minutes. And the thing that I find really interesting about this quote is that it shows sometimes that invisible work that goes on for nurses. A lot of times we change processes in the hospital, not knowing who it affects and who is delivering this care. And oftentimes it is the nurse that is delivering a lot of this really interesting, high viable care that we provide here in the hospital and the health system, both in the hospital and outside. So on this next slide, we'll talk a little bit about the integral part that nurses play in healthcare delivery, both inpatient and outpatient. And so here we see just a simple diagram, and many of you will know this incredibly well, and I won't spend too much time here, but just to say that patients are in need of nurse-led care in so many ways. And here are three elements that we like to focus on within our research: is the education and coaching that nurses perform, the care plan adherence and monitoring, and then the on-demand assessment and triage. These are three specific things that when nurses are practicing top of license within scope, provide a huge amount of value to our patients, both again in the hospital and outside the hospital. And we know that when this happens and happens well, our patients that go home with really complex wounds surgery, oncology, heart failure are four examples of really high need patients that really get a lot of value from this nurse-led care, can have a huge amount of value. When that nurse-led care doesn't happen for some reason, when we don't have those nurses in place, we see patients coming back to the hospital all the time for numerous different reasons, and the reasons are multifactorial. But we found that from numerous studies that we've read previously that nursing care is really the glue that sometimes allows patients to successfully get the care they need in the home. And one way that we can structure this is around the Quadruple Aim, as we try to break down the nursing role in the healthcare ecosystem. And so for patient experience, without nurses, patients lack a lot of access to care. And that goes without saying in many ways. But I would include in here informal caregivers that are oftentimes those individuals that are help facilitating these care plans that we're sending patients home with, are oftentimes left out of the loop, and nurses play an integral part in helping them to be educated and to be informed to be able to perform their roles as informal caregivers. For the patient provider experience, one thing that we all know is that providers aren't able to efficiently reach all their patients, especially some of our most vulnerable populations, between their care visits, without an ability to have nurses help maintain some of that communication with patients. And in many ways, this is evidence, and one thing that we're seeing a lot in healthcare is this in-basket crisis that Topher Sharp, our CMI, always talks about. And one example he gives is that between 2019 and 2021, the patient engagement has doubled, and the volume of our patient messages have doubled. And this is a cry of the patients needing more access to care and needing more information and needing more time with providers. And nurses are able to provide that time. This also leads to greater burnout and churn for providers. To focus quickly on quality of care, without nurses, we have a decreased continuity of care. And we'll talk about that a lot more in a few minutes. And then cost of care. Without nurses, we see this leads to, in many ways, complications, readmissions, increased lengths of stay, a lot of challenges that end up costing the health system more in the long run. And so I've heard a quote many times that nurses are the heart or the backbone of healthcare, and I believe that in many ways. So in the next few slides, we'll talk a little bit more about some concerning trends that we're seeing. And many of you, again, will be very familiar with this, but unfortunately, we have an existing gap between the current supply of nurses and the demand for care for patients. And this gap is widening. So right now, there's about 50 million patients estimated that need care in the home. And again, these are pre-pandemic numbers. We also know that there are about 3 million nurses in the US. 2/3 of them practice inpatient, about 1/3 are outpatient. And that one of the 1/3 or 1 million nurses practicing outpatient, about 50,000 are working in home care. That's roughly a 1 to 1,000 ratio of patients to nurses, which is concerning. 84% of health system operators state that there's a critical nursing shortage currently today. And this is despite the scary numbers that we'll talk to you about in just a second about the number of nurses that are considering leaving the profession. And again, you can see that this deficit triples in the near future as this silver tsunami of aging adults with multiple chronic comorbidities move the healthcare system in a more time-intensive, increasing demand way. And so if you go to the next slide, we can talk a little bit more about what concerning things we're seeing with nurses leaving the profession. Again, not new or probably surprising to anyone here, but this problem doesn't seem to be going away anytime soon in terms of nurses feeling burned out and frustrated. A McKinsey report recently called out that 33% of nurses plan on leaving the profession by the end of the year. This is 1.5 times worse for those nurses who are in home care. And here are a list of reasons as to why the McKinsey report felt that that was the case, between them feeling a lack of a safe environment, a lack of work-life balance, not feeling like they've got caring or trusting teammates. Again, this is a national perspective. They feel like they're not being able to do meaningful work, and that they have an inflexible work schedule. So in the next slide, we'll talk a little bit more about the health system perspective, trying to put these different pieces together. And one thing we find is that in many ways, health systems, speaking broadly, speaking generally, are asking nurses to do more. And then what results from this, again, a lot of this falls on top of our specialty nurses as well in these specialty clinics. They're asked to do more post-op calls, call patients back in between their lunch hour, when they get on shift, after their shift. The demand is high and increasing. This results in increasing staffing costs, specifically for traveling nursing and churn and other nurses that need to be backfilled to be able to support the health systems, which ultimately leads to insufficient time with patients, which leads to poor outcomes, increased nurse burnout, and overall costs for the health systems. So now getting past kind of the doom and gloom, I'd like to talk a little bit about the opportunity that we have as health systems to really dig into how we can rethink nursing care within the health system. And the good news is that currently today, one report notes that there are more than 500,000 nurses left in person work that still want to be able to participate in opportunities. And these can be nurses that are retiring, that are burnt out, that are needing special accommodations, or that are on leave for family reasons. But there is an opportunity to be able to provide some of this incredible care that nurses provide outside of the traditional ways that we think about performing nursing care. And so on this next slide, we'll talk a little bit about some of the interesting learnings that we found through a pre-pilot analysis or tally sheet that we implemented here at Stanford and from other sources and other researchers suggest that about 25% of a nurse's work, and this is generalized between inpatient and outpatient, can be done remotely. And some of these tasks include coaching education, clinical evaluation, ongoing monitoring, talking about discharge instructions. Many things that are currently being done in person could be done virtually, and in some ways are enabled to be done more efficiently remotely. So that's a really exciting thing, that we can maybe offload those in-person nurses from the strain and stress that they're experiencing now, and can take off that 25% work to mobilize the new population of nurses to help with that work. On the next slide, we talk about the interesting fact that a lot of health systems already have this capacity built into their structures. And so a lot of, again, we've spoken to about 20 different health systems all across the country and understand more about their nurse staffing and their dynamics. And it's roughly around 10% of nurses that are retiring or on work restrictions or medical leave, many of them that are part-time or per diem, are able and interested to be working remotely, but are unable to work in person. They're seeking those opportunities, which is a really, interesting opportunity for us to unlock that internal nursing capacity within health systems to be able to do this work. And so the challenge truly is, in many ways, the challenge is to mobilize a population of both generalist and specialty nurses to work remotely at the top of their license, all while seamlessly integrating into the care that already exists in those processes in the clinic and the hospital. And equally important is meeting patients where they are to really provide patient engagement, make sure that they are participating in that care. And so in order to do this, one way that we aim to rethink, one of the challenges to really mobilizing that populations are a few different things. One is the logistical constraint, one is the technological constraint, and one is the clinical challenges. And so from a logistical constraint, it's really hard to load balance a variety of nurses, both specialty and generalist. Finding that right mix of specialty and generalist nurses, then matching those patients to the right nurses at the right time, making sure there's a good user experience for both the nurses and the patients to be able to do so. addressing all access issues for patients that are older and have multiple chronic comorbidities. And clinically, being able to address some of the siloing that happens, the variability that happens between our different service lines and clinics in the hospital, and then training and maintaining quality of that nurse-led care. So in order to kind of address these problems, what we strove to build was an ability to unlock that nursing capacity by identifying and mobilizing those nurses, providing training to help them understand how to perform virtual care and how to understand how the escalation protocols work, by expanding their reach beyond the clinic walls, and then by automating a lot of those things that were happening by hand that could be done by a computer, and doing that intelligent matching, building everything with human-centered design so that it's intuitive to use, and building in escalation protocols that allow a nurse to be able to escalate care to an in-person nurse or a specialty nurse or their providers or the ER urgent care seamlessly so the patient always gets the right care at the right time, and making sure that we're integrating with those existing protocols that exist within health systems, and make sure that it's available 24/7 as possible, because patients, we know, need care all the time. And so on the next slide, we'll talk about how we really tried to test and understand these aims. And this was in partnership with the ESU. We feel really grateful for their help in helping us look at this vision of the way that we thought we could change healthcare delivery, and putting a robust research perspective on how we could start to test some of these hypotheses. And these aims include evaluating first the feasibility, adoption, acceptability, and clinical appropriateness of a virtual nurse-led care model using the PocketRN app in the setting of wound care in the home. Again, we feel really lucky to have had this partnership where they helped us identify and address early problems in implementation and functionality of the app. And then again, focusing on those 4 implementation outcomes of feasibility, adoption, acceptability, and appropriateness, specifically for patients that we knew would be older and had complex care, specifically wound care patients in their homes. And then to think through how we could scale this idea and think about next steps for doing this type of work. And so in the next slide, next we will talk about the methods just briefly. Again, this was an IRB approved study. Eligibility criteria included adults from 1999, and they had to be living in a home, and they had to have providers at a specialty Stanford clinic, specifically the Advanced Wound Care Clinic and Vascular Clinic. The nurses also had to be Stanford nurses, be part-time or per diem, and have all the access to the EMR and the credentialing they needed. We recruited patients virtually or in person with a CRC. And as mentioned before, it began in July recruitment, or June for the Advanced Wound Care Clinic, November for Vascular Clinic, and we finished in April. And so just to walk through really quickly what this looks like for a patient using this application. So a patient would be connected with the application in the clinic or at home. They'd be introduced to it. We would do all the virtual onboarding and orientation for the patient. They would meet with a virtual nurse for the first time just to review their care plan so they could interface with the app and meet these nurses over a video visit. And then these nurses would perform preventative visits where they would call the patients every 2 weeks to check in, to review their care plans, do education coaching, or they'd be available on demand during difficult times to typically staff our clinics. So in both of these clinics, they wanted us to focus on the after hours between 4 and midnight. And so they would be able to call in reactively during those hours. From the nursing perspective, what this looked like, we were enabling them to perform on-demand support from home. So all these nurses were at home, had access to the Stanford EMR, Epic, from a Stanford issued computer. The nurses were trained on how to use this information and trained on some of the clinic processes for specific to the Advanced Wound Care Clinic and the Vascular Clinic. They would log on from home, and this was always when they were off shift. So they were never distracted with other in-person work that they needed to be doing. A lot of times they were at home with their families doing other things, and we could send them a text to get them pulled into to meet with patients. And then they would start accepting patients and conducting those visits. So together, what this put together was this virtual nurse-led care model where nurses could help fashion these personalized care plans for patients, where we would do care plan review, regular check-ins, and on-demand access. We would do needs-based matching. So if a patient got on the application and said that they wanted to meet with a patient about a very specific procedure, like a total contact cast, they could then meet with a nurse that had spent years working with patients, understanding concerns with total contact cast, which was a specialty nurse in the Advanced Wound Care Clinic. So we were able to direct the patient to the right nurse with the right level of understanding and education. On the next slide, we'll talk a little bit about the customized and automated protocols. So this was a really interesting opportunity for us to work with these clinics closely, the Advanced Wound Care Clinic and the Vascular Clinic, to understand what is the terminology, what are the patient journeys, what are the process flows for your clinic on how you want care escalated, and how do we make sure that some of our generalist nurses that get matched with patients because maybe the patient's initial concern is something general or doesn't require specialty training initially, how can we alert them to specialty concerns that do get routed to the appropriate providers? So we spent a lot of time thinking about these escalation protocols and automating and leveling up and training these different nurses to understand how care typically happens in that clinic. And then to talk more about the methods of the evaluation science unit that performed a mixed method evaluation. This is a quick diagram showing the qualitative methods in the interview flow diagram. And these were semi-structured qualitative interviews with patients and nurses. They would perform this rapid qualitative analysis after each interview series that would provide us lots of insight that we could implement almost immediately in some circumstances, different things that would make the enrollment easier, improve patient expectations or nurse expectations, or make sure that there was safety in place. And this was with the Stanford Lightning reports to really help identify some of those workflow challenges or any changes that we need to make along the way. And you can see that there was a number of patients approached and a number of interviews conducted in both the Advanced Wound Care Clinic and the Vascular Clinic, as well as both float nurses, who are our generalist nurses, and wound care specialized nurses. On this next slide, we talk a little bit more about those specific outcomes. We won't have a lot of time to get into the details here, but again, really interested in acceptability, adoption, feasibility, and appropriateness. And a good lesson learned for me in working with the ESU is how do you think about introducing these novel healthcare delivery technologies into a health system, and where do you start to think about that implementation process? And so I learned in our partnership with the ESU how you think about these different implementation outcomes to begin that process. We've got a long journey in front of us in terms of how we continue to understand the implementation and use of PocketRN in different health systems and different settings. It was really interesting to learn this approach, utilizing these implementation outcomes to make sure that we could really understand and test these different hypotheses. And then, of course, if you've got time later, we can talk a little bit more about the data types and the sources for that data. But to move on to the results section, in the end, there was a total of 64 patients enrolled. 49 came from the Wound Care Clinic and 15 from the Vascular Clinic. We had 73% of the patients were returning patients. The other percentage were new patients that were newly introduced to Stanford specialty clinics within the first 2 weeks. Patients tended to be older, on average 62% that were 60 years or older. A majority were whites, although we had a good component that were Asian or had Hispanic, Black, Hawaiian, or others. And then the patients, both clinics were similar in terms of the race and ethnicity, age, language preference. Again, we only had abilities to, part of the inclusion exclusion criteria was that patients were proficient with English with our caregivers, given that we had limited abilities to provide nurses with interpretive services. On the next slide, this is just a breakdown of the call types. And again, as you probably realized from before, we had a few different call types. Some were reactive calls, as you can see in that deep blue, where patients would call in reactively on PocketRN between those hours of 4 and midnight. They had some concern, they got on the application, they pressed that one button and selected their indication for need, and we matched them with a nurse within 5 minutes. Others were proactive, or these check-ins, where we would schedule calls with them to call them and see how they're managing their care plan, see if there's any education opportunities or abilities to really help them adhere to their care plans. We had orientation calls, then we had post-op calls, which was Stanford Healthcare house-wide initiative to perform a 48-hour follow-up call after procedures. And of those calls, you can see that a majority of them did not need an escalation, 92%. Some of them required an escalation to a PocketRN specialty nurse, which meant that they would meet with a generalist nurse on PocketRN, and that generalist nurse identified some concern that qualified to meet with a specialty nurse. And so we would internally escalate that to an available Advanced Wound Care Clinic nurse. And then they would get their care taken care of. Some involved sending a direct message back to the clinic providers. Some involved creating a new clinic appointment. And then a few involved sending the patient to the ER for emergency services. And it was clearly stated that the goal of PocketRN was to help address emergency or help navigate patients' care, but it was clearly stated if there was an emergency that you were to call 911. But there were a few times where patients called in regardless and wanted to meet with a nurse. And in those scenarios, we were able to navigate the patient to the correct care appropriately. So on the next slide, and a really interesting thing that we learned as well is how often our concerns can be addressed by a generalist nurse or generally trained nurse versus a specialty nurse. And we found that about 80% of the time, which was a big question that came up when we were first exploring this topic, knowing that there's a lot of specialty clinics and specialized care that happen in our large academic medical centers. One concern we had was about mobilizing both generalists and specialty nurses and knowing how to transition the care between these two different types of nurses with two different experiences. And so one thing that we learned during our brief clinical study was that a good portion of the questions that patients had could be addressed by generalist nurses. And here's a list of those common things that were commonly addressed by generalist nurses very well. And then those things that we needed that specialty nurse to be able to address. And having the ability to easily and fluidly move back and forth between the two was key for success in this pilot, because sometimes you can predict when a patient's going to need a specialty nurse and sometimes you can't. And so being able to understand this ratio, but also have a dynamic, we found was a really interesting result of something that we were attempting to understand and continue to understand through this pilot. So on the next slide, this is just a little bit of a pre-post to show you a little bit about information that we saw and data that we gathered before implementing this virtual nurse-led care delivery model versus afterwards. And within the two clinics, there's on average 6 specialty nurses helping to manage hundreds of post-op and or reactive patient calls coming into clinic. And these nurses are very busy. The number of the amount of work that they get done in a day is incredible. Only able to, on average, to reach patients about 60% of the time. And typically those calls were about 5 minutes long, and those were telephonic. Nurses were oftentimes or intermittently working overtime and trying to call patients after their shift to be able to get back to patients and to be able to meet that demand that was coming in. And oftentimes there was only limited hours that they would be available between the clinic hours. So after the intervention, we were able to mobilize a flex pool of 20 nurses. They were able to reach more patients for a number of different reasons, partly because they would attempt to call patients more than once, and partly because we would text and call and message them through the app and had different modalities to be able to reach them. And on average, and the really interesting point is those calls were 25 minutes long. These nurses had more time to spend with patients because they weren't busy with other in-person work. And so they can really dig down on understanding the patient's level of understanding of their care plans. We were also so able to mobilize a few untapped nurses that wouldn't have been able to practice in person because of certain restrictions, whether they had recently had a surgery or on medical leave. And we were able to help them utilize not only that clinical operational knowledge that they had, or not only that clinical knowledge, but that operational knowledge. And that's one point that we can talk about a little bit later as well, is that nurses come to the table not only with a lot of clinical knowledge, but operational knowledge, understanding how the clinic works to be able to provide to these patients. And then we saw of those individuals interviewed, of the 11 people interviewed, about roughly 30% had mentioned to some degree that they had used PocketRN after hours to avoid going to the ER. Again, not statistically significant and just an interesting thing to mention. But to get more into the Esu evaluation, speaking to a lot of these really interesting outcomes that were evaluated, talking about clinical appropriateness, one of the key themes that came out was access. Patients expressed a lot of gratitude for having this resource available after hours and being able to answer questions immediately rather than having to leave a message and wait. One patient mentioned it was really nice when you come home from the hospital and they're giving you directions, especially. There's so much going on for you to forget about going on, you forget about a lot of things. Another was just the quality of care, knowing that the nurses know that the format of the teleconference allowed for a higher quality of care. And again, that's compared to the telephonic approach. Having a video visit does provide a lot more information for these nurses being able to see their faces, as mentioned by Nurse 5. On the next slide, we talk more about the satisfaction with PocketRN, with patients feeling that they were satisfied with the virtual care, stating that the advice the nurse gave me was very helpful and made me feel more relaxed in the home. Another nurse mentioned that one of the pros for her was being able to do this work from home. She could wear her pajama bottoms with a scrub top on, and it was more comfortable for her and to be with her family. A lot of our coworkers are moms. I know that's really convenient for them. And then for nurse comfort level, So it's talking about the training, the previous expertise, and the experience on the platform impacts satisfaction. Knowing, as this nurse mentions, just trying to know what to expect. And they did prepare us for it, but still, it's just something so different different than anything any of us have ever done before. Mentioning that this is a new way for nurses to deliver care, both virtually and in this interesting way where these nurses have never been in the advanced clinic for many of them, and having to interface with those nurses. The more experience they have, the better they can do. With the satisfaction with on the next slide, with the feasibility and acceptability. So there was some challenges with patients having literacy with telehealth, and having difficulty not identifying themselves as high tech, and having difficulty navigating an application. Also with equity was a common theme that came up as well with pay equity between nurses and the clinicians. At the beginning, I think all my friends too were excited about getting paid while at home. And the way that we paid these nurses were according to the Corona contracts and existing regulations within Stanford that allowed them to get paid 0.5 while waiting to be matched, then 1.5 when talking to patients. And that was a consistent theme, is around how do we think about structuring the payment for these nurses. So moving to the next. And then lastly, adoption. We realized that there was less use when patients already have support. Many patients felt like they already had everything they needed to get the care from Stanford, and that many shared that they didn't use the platform because they felt like they already had existing resources. And so this is something that we're trying to understand, is how do we identify those patients that need more resources, or those that don't and need that help. And there's ongoing evaluation with ESU to really dig into some of the demographic information as we think about who does the solution really help and how can we provide access equitably to all. On the next slide, we can move into the discussion. I can just go over these really quickly. We did have some limitations, and one was a small sample size. It was really tough to recruit patients during the COVID pandemic, when our CRCs were oftentimes not allowed to be in clinic. And that was the pandemic-related recruitment challenges. Also, the English proficiency as a requirement did affect our abilities to enroll more patients that we felt like could have benefited. On the next slide, there was a lot of lessons learned. And many of these are amazing lessons we learned with the ESU, which is we were able to address some major known gaps in telehealth with positive feedback on integration into standard healthcare services, acceptability and adoption for both patients and clinicians. We found out that patients with a new diagnosis are more likely to use PocketRN. Having a caregiver portal would dramatically expand adoption if we can include those caregivers in that process, and having a zero tech option for patients that really had insufficient or lacking technology health literacy to improve feasibility. We also learned the value of that proactive check-in and helping change patient behavior, as well as enabling nurses to practice at the top of license. All those are interesting topics that we can talk about, and I'll skip this. We can go through this slide really quickly, but there's so much more for us to learn, both around understanding more of the expanding use cases outside of wound care, talking more about other healthcare outcomes and cost of care, and exploring some of these CPT codes that can be used for nurses. That Stanford nursing leadership is actually leading the way in the nation around how do we help nurses utilize some of the CPT codes to capture the value that they provide to patients in the home. But lastly, we would like to there's so many people to thank in this process, from Mary Fukai, who's our PI, to Gretchen Brown, was our leader within the Stanford Nursing Leadership Department, that really helped us pave the way, the Catalyst team, the Evaluation Science units, and all the others that were integral in helping us try to change the way that patients access care and that nurses deliver it. But with that, I realized that I probably started talking really fast near the end, hoping to get through all of it, but would love to pause here and see if there's questions that anyone might have about any of the information presented today.
Thank you so much, Sam. And I'm happy for anybody we can do a round of applause. Thank you, Randy. And I'm happy for anybody to unmute who wants to jump in or to put a question in the chat. I will say I've got lots of questions, Sam, but I think for this group in particular, the lessons learned and, where there were missteps or you needed to redirect along the way. I know that's not like the front and center story, but I think this group would be particularly interested in a couple of places where there was some major barrier that you came up against that you had to think about how to work around.
Absolutely. I think that the two that was identified with the ESU around the caregiver portal and that zero tech solution, I think were really interesting ones and a great place for us to start. So I think sometimes we don't fully appreciate how involved informal caregivers are on the care of the patients that we send home from the hospital. I think we intuitively know this to a certain degree as we're talking to family members and trying to explain to them about this new diagnosis or educating them. But we oftentimes don't realize how involved they are in the care and the intuition that they have when the patient gets home that something is wrong. And so we learned quickly that for the population of patients that we were working with, again, average age older than 60 and multiple chronic comorbidities and complex wound care happening in the home, caregivers were doing a lot. And so having a way to bring them into the conversation was really key. And so we've been working on that since, and have created since a caregiver portal where we can provide them the right provisioning to be able to even meet with a nurse on behalf of the patient if they've got the right permissions and to be involved in that care. So that was a huge learning for us. And with the zero tech solution, it's interesting in digital health. A lot of things changed for us with COVID, as we all know, with virtual care and how much we've learned about what we can actually do with virtual care in the right scenario. And a lot of individuals talk about the limitations of adults or older adults using cell phones. And we definitely felt that. We aimed from the very beginning to build something that had an appropriate user experience or was built around human-centered design for older adults. But we learned that some needed a landline, needed an ability to communicate with a nurse over landline. And so we spent time to really build out those processes in a Hipaa compliant way for patients, even those that only had a landline, to talk with a nurse. And so luckily we were able to get there. But again, that was a good learning and insight for us, is that if we're going to put a solution out there, it better be equitable for absolutely everyone and not to be shy about changing the technology in a way that does really require a lot of time and effort, but will reach that small percentage of patients that might not have an ability to utilize the technology that you're putting out there.
We've got a couple of great questions coming in on the chat. Kathleen, do you want to chime in about your HIPAA and insurance coverage questions?
Oh, hi. Thank you, Sam. Great presentation. Really, very interested in this stuff. So I'm just curious to know, like, how you protected patient privacy, and was there issues with insurance? How is this something that insurance will pay for in the future? Kind of like that.
Great question. So the HIPAA question is a really important one that we identified in the very early days after talking, with lots of people at the Stanford Biodesign Department and many others about the importance of that. And so one of our first hires was a security engineer that really understood HIPAA compliance. And so everything that we built out on the app, every process that we had around texting, every way that we interfaced the PocketRN staff with the nurses around PHI had to be done in a very meticulous way that made sure that we were never compromising PHI. And so it did affect a lot of our processes, a lot of the efficiencies with how we could text patients, what we could text, how we enable the nurses with all the right access, but not to be sharing too much of that information with others that shouldn't be provisioned to have that information. And then, of course, having specific agreements with those software technology that you're utilizing to facilitate this care. And so as a digital health company, you're always deciding, what do I build and what do I buy? And for those things that you buy, a lot of the times it's because something is already HIPAA compliant and you can get a BAA in place that you can make sure that it really allows you to do things in a safe way. And to your question about the insurance, we aren't currently billing insurance for these services. But again, we've worked closely with a few of the leaders at Stanford who are on the bleeding edge of this work to say, we need to make sure that nurses are reimbursed for their time and their effort. And so Charlene Platon is a nurse leader at Stanford who's exploring using CPT codes as including 99211 to be able to reimburse nurses for this time, which is an existing structure for them to be able to do that. The goal in the end is to provide enough data back to the insurance companies that they should pay for this incredible nursing work that's happening, because we know that there's a lot of value for nurses to give and that patients need greater access to care, but it's getting to that point of having data to present it to them to create those new processes.
Great, thank you so much.
Of course.
And Sam, just building on the existing processes point, I think the next question, Kiana Scott, you're welcome to chime in. It's really about what is the difference between the existing clinical advice services department and PocketRN. Kiana, did you want to chime in?
Sure. Yeah, that's exactly my question. Hi, my name is Kiana Scott. I work in the CEPD as a nursing professional development specialist supporting ambulatory care. And prior to this role was also a clinic manager who oversaw some of our cardiology teams, including our heart failure nurse coordinators who would perform post-discharge calls. So definitely see the value in this in reducing readmission rates. So I just wanted to understand what the difference in the service provided would be between the PocketRN and the clinical advice services RN, and also if this would be expanding to other clinics and specialties.
Absolutely. So we, I've loved the interactions that I've had with CAS, and I think CAS performs an incredible service, specifically an ability to be available after hours for patients that call in with questions. I know that the numerous service lines that we've worked with have used CAS both for proactive calls, 48-hour follow-up calls, as well as reactively when patients call in. And it's an incredibly robust and efficient and well-run system. I think the place where we see PocketRN fitting in is around the ability to longitudinally follow up with patients using video visits to enable care plans. And so to be a connection for nurse-led care delivery in a bit of an expansive way, to continue to follow those patients out for a longer period of time, to make sure it's done through a video visit if possible, to build that patient rapport, and to really be some of the glue between the patients in that clinic. And so we see working with CAS at Stanford is a really important thing moving forward, and would love to find how we can kind of continue to fill those gaps for patients as they currently exist. But definitely an area for us to continue to explore, as well with the different service lines. Would love to explore different use cases in areas. And I feel like after this feasibility study, where we could validate in many ways the quality and the safety and those 4 implementation outcomes as described by the ESU, is a great time for us to really explore other patient populations where there's a lot of high need for that type of work. And as well as in combination with CAS, I think that caregiver piece is a really interesting way that we can work with CAS, as well as how do we include other individuals outside of just the patients to be able to get the care that patients need.
Yeah, and Sam, hi, this is Marie. Just to piggyback off that, especially the caregiver piece, one thing we learned from the study was the value of including them in that 48-hour post-op, post-procedure call. We definitely had families who had suggested scheduling that at a specific time because they wanted their loved one or caregiver on that call as well, so they can hear those post-op instructions and make sure that the people taking care of the patient at home are aligned and on the same page. So that was one really interesting learning as well from the pilot.
And Marini and Sam, I want to invite you guys to put your contact information in the chat so that people can reach out to you. We're not officially wrapping up, but I do tend to I think we like to end at 12:50, so people have a little bit of time to get their lunches put away before on to their next meeting. I will say, if you want to stay on, Sam, if you have a little more time, we've got some more questions, but I just want to make sure that we officially say thank you all for coming, and thank you, Sam and Marini, and have a lovely Tuesday. And then we'll continue digging into the meat here. Sam, I see the next question from Honor Magan is about balancing continuity of care and flexible working structures. Do you want to comment on that?
Absolutely. I think that's Honor, any other things that you would add?
I'm just from Australia, where we do a lot of telehealth because of the fact that we have such a geographically sparse population. And one of the biggest issues that patients describe is that they hate saying the same thing over and over again to a provider. So really interested in how you tackle that.
Yeah. So this is, as you have probably experienced in the US, we've got a lot of fragmentation of care as well, as we do these different handoffs from inpatient to home health, back to your primary care provider. A lot of times there's really minimal communications between those parties. And so one of the principles that we built PocketRN around was that continuity of care. The fact that your surgeon that discharged you from the hospital can use his or her nurses, as well as those additional nurses at Stanford that have visibility to Epic and their EMR to make sure that continuity of care is there. And in terms of meeting with the same nurse over and over again with those proactive visits, is something that we've built out through scheduling on PocketRN. And so if you really enjoyed your interaction with this nurse and you just clicked and you built that patient rapport, we can then schedule that same visit with that same nurse whenever it's convenient for the patient. Again, it could be a Friday night at 11 p.m. It's kind of the interesting ways that we can predict some of those flows. So it's a little bit more of a dynamic staffing model. And then for those patients that call in reactively and that nurse isn't available, it's our job to make sure that the information is there so that they're not asking that same question and the nurse feels enabled with what happened previously. And luckily, we can do that more efficiently than some interactions just based on the fact that there's not all this other data that we have to like jam into these notes that make it harder to read and digest for the next nurse coming on. A wonderful question.
Yeah, having the EMR integration was actually seen to be pretty important, pretty central. Which has interesting implications for Stacy Valender's question, which is about, what do you say to a health system leader that wants to build them PocketRN themselves, or integrate PocketRN as it is now into their systems? What are your thoughts around that?
Yeah, so we think about this question a lot as we interface with lots of different health systems, including individuals that integrate delivery networks like Intermountain. And there's the infrastructure to do what we're doing at PocketRN. Aspects of it definitely exist, whether it's a digital front door or different ways by which they're trying to improve patient engagement in their care plans. The interesting things I think that are missing oftentimes is an ability to think about mobilizing the nursing population and then breaking down some of those internal silos that exist to really leverage matching of specialty from generalists to specialty fluidly. And then a few other interesting things that we could talk about a little bit more, Stacy, about why is it hard for health systems to do this type of work? And again, it goes back to that one slide where we talk about logistically, there's some constraints that they run into, as well as technologically, and then clinically breaking down some of those silos. But it's a great question. And for a health system that is interested in integrating PocketRN, the nice thing is that we can meet with the nursing leadership and understand where is that 10% of nurses that currently are on the bench wanting to work, but unable to work in person due to some sort of restriction or inability. We can mobilize that population of nurses and perform an amazing amount of patient care with a small group of nurses that can then be expanded later. And we can work with them as well to do all that interesting implementation work around the escalation protocols. Now that we've created in many ways an interesting playbook with Stanford, co-collaborated with Stanford, how to build out these escalation protocols and how to think about engaging patients in the home. So there's a lot of interesting things that we could talk about, but it's a fairly robust and quick way to implement quickly virtual nursing services for any health system that would be interested in utilizing it.
Thanks, Sam. And I think this is our last question, unless somebody wants to jump in or add something in the chat. This is Randy Painter. And Randy, you can jump in if you want, just asking about range of health literacy in addition to tech literacy. So what, if any, provisions are there for adjusting to health literacy levels? Randy, I see your video's off, so you may not be at a place where you can chime in. That's fine.
Yeah, I really like, this is a fascinating question. And my question might be a little bit of an extrapolation from this. But one of the reasons that I really like the video visit for these nurses, instead of it being telephonic or instead of it being, an AI-driven bot that's trying to provide education to patients, nurses in many ways, as other providers are trained to be able to some degree, assess a patient's ability to understand what they're talking about or to understand their health literacy. And we can even teach the nurses on the platform different methods to be able to do that assessment if they're not already familiar with their previous experience, but to also enable them with the time and the ability to do that. And in many ways, that human touch side of what nurses do and the time and the opportunity we give them to connect with patients and say, spend as much time as you need connecting with this patient to make sure that they understand what's going on and understand their care plans. Because if they don't, that's when we run into those readmissions and complications happening at the home. And so we try and enable them with time, the technology, the ability to connect with them over Zoom so they can have that face-to-face visit, as well as additional education or training on top of what they might already have to be able to assess a patient's health literacy. But maybe I can pass off to Marini as well to comment here, because I know that she's got a wonderful experience as a nurse doing this day in, day out with both pediatric patients and their family members.
Yeah, no, I agree with everything you've said so far, Sam. I think it just goes back to the value of that proactive check-in, because I see the nurses in the pilot like really utilize that time according to what that patient needed. And so for some patients, the nurses saw that it was just important to help them with compliance. And so talking through whether or not they were sticking to their care plan, maybe coming up with suggestions on how to make that easier to incorporate into their lifestyle was like a conversation they had. Meanwhile, in other situations, the nurses realize in that conversation that there is a gap in the patient's understanding with their care plan. And so the time spent there was really focused on just education, breaking it down, making sure that the patient really understood what those instructions were when they were discharged or when they were last seen in clinic. And just like you said, I think nurses have that experience and intuition to know what's needed with that time. And that proactive check-in is really just that platform that they can use, that time that they have structured to do what they need for that patient. So that was very exciting to witness and learn from the pilot for sure.
And I'll just add, and I think this is our last moment together here, that I think the average number of minutes was 25, but the range was very large. I think that the longest session was maybe an hour, and so the time, just having that time available is one way to address differences in health literacy. Sam, Marini, thank you so much again. I feel like this has been such a successful and interesting conversation. And thanks everybody else for joining and for staying for the conversation. All right, and I think we'll let you head to the rest of your day. Thank you so much. Bye-bye.
Thank you for the opportunity. Thank you, Katie.
Thanks, everyone.